We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question number 1. In a female patient, there is a complaint of vision loss, specifically affecting the right halves of both eyes. Where is the lesion located? Your options are. And the correct answer is left optic tract. Here's the explanation.
Left eye temporal is gone, right eye nasal is gone. Isn't it? So when left eye temporal, right eye nasal is gone. When temporal is gone, what is the field effect? Nasal. So left sided temporal is gone means nasal field is gone. Right side temporal field is gone. Because all the field effects are on the same side, this is what is, which side is it? The shaded part, as you see, is towards your right side. Do you realize something? We are talking about examples of left-sided lesion. So a left optic tract lesion leads to right homonymous hemianopia. Why do you call it homonymous? Because of both the eyes, the defect is on the same direction, right? So this becomes right homonymous hemianopia. Can we remember this? Left-sided lesion means right homonymous hemianopia.
Question number 2. What is the probable diagnosis for an infant brought in with symptoms of excessive tear production, sensitivity to light, and blepharospasm? Your options are. And the correct answer is congenital glaucoma. Here's the explanation.
Primary congenital glaucoma. We can classify this as true congenital. True congenital means the child is born with it. Then infantile. Infantile is less than equal to 3 years of age, and juvenile means more than 3 years. So here infant is 1 year, but here infantile means less than equal to 3 years, and juvenile is more than 3 years. Now pay attention. Now let's understand here. In a small child, the sclera is very soft. So whatever pressure is rising in the eyeball is causing stretching of the sclera and enlargement of the eyeball, and this is what is called ophthalmos. Okay, so this is what is called ophthalmos. So what is ophthalmos? It is nothing but enlargement of the eyeball, which will happen when either in true congenital or infantile, but not in juvenile. Then we talk about why it is happening. Apart from this, what can be the pathogenesis? So pathogenesis, mainly just learn with me, there is angle malformation, which we can also call as trabeculodysgenesis. Okay, so trabeculodysgenesis. So because of this, there is impaired drainage, more aqueous, leading to more pressures and glaucoma. Okay? Okay, Barker's membrane was also something I myself used to teach till last year, but again this recently it is said that now it is considered not very important, we shouldn't mention it. Okay, so Barker's has become an old concept, we will not mention it. We come to angle and malformation, or we call it trabeculodysgenesis. So everything is included in that, whether it is problem, generally the problem is some anteriorly located iris insertions. Okay, so commonly it is anteriorly located iris insertions. Anyway, once we know what is trabeculodysgenesis or angle malformation, now how this child will present. So that was about pathogens. Clinical features. The child presents with watering. Of course, the parents are noting this. Then photophobia, you all know what is photophobia, intolerance to even normal light is photophobia, and blepharospasm. That is, what is blepharospasm? When the lids are being closed due to this photophobia, we call it blepharospasm.
Question number 3. A contact lens user presents with the following clinical picture. He has had watering, redness, and foreign body sensation in the eye for the past 2 months. What is the most probable diagnosis? Your options are. And the correct answer is giant papillary conjunctivitis. Here's the explanation.
Overwearing of lenses can also lead to This was also recently asked. Can we talk about that? Overwearing. That is why I told you those 4 points of using the lens. Don't overwear it. So overwearing syndrome due to this contact lens can lead to giant papillary conjunctivitis. We have talked in conjunctiva chapter here. So it can lead to giant papillary conjunctivitis, right? And also what is important here, that when you say overwear syndrome, actually this is serious because it is causing hypoxia of your cornea, and any hypoxia of cornea is leading to edema in the cornea. Okay, so corneal edema, so this becomes serious, corneal edema and corneal neovascularization.
Question number 4. What would be your diagnosis for a patient who has a previous trauma history and is currently experiencing diplopia and following findings on CT? Your options are, and the correct answer is blowout fracture. Here's the explanation.
Let's write the points here. Can you see here? This patient has got a blunt trauma in the right eye, because of which, what are the things and features we can see here? So first of all, what are blowout fractures? Number 1 point, fracture flow due to blunt trauma. I have already talked about that the weakest part is posteromedial. And why there is a fracture of the floor? Write down the mechanism is buckling effect. Due to so when there is a blunt trauma, there is a buckling effect in the floor which leads to its fracture. Okay. What further we will write here, that any blowout fracture can be pure or impure. Pure we say when infraorbital rim is not involved. So when rim not involved, then we call it pure. Impure means infraorbital rim is involved. Infraorbital rim is involved. Then this is your impure. Okay. Now we talk about features. Think yourself, we are going to learn in my style, outside to in. If there is a blunt trauma, first black eye, isn't it? We call it periocular ecchymosis. So first would be periocular ecchymosis. That is also called black eye. Now I want to point out here, this is not panda eye or raccoon eyes. That is seen in fracture base of skull, right? Roof fractures, not in floor fractures. Secondly, what you will see, think again, decreased sensation on the affected cheek, the side, of course, any side wherever the trauma is. So decreased sensation on the cheek. Okay. Why it is happening? This is due to damage to infraorbital nerve. Damage to the infraorbital nerve. Now, how will I know how will I know whether the sensation is less or not? We ask the patient to close the eye, we are touching the cheek with the cotton. He has to count whenever there is a touch. So it can be on this cheek or this cheek. So the affected side, you see, he starts missing the count. Okay, so this is the way we will judge whether the sensation is good or not. Then what else you are going to get? Just you saw in that clinical slide, I had gone inside. This is called enophthalmos. So in Horner's you had learned was apparent enophthalmos. This is true enophthalmos. And of course there can be diplopia, right? Now why are you getting a diplopia? Diplopia will happen because of few reasons, isn't it? So first important reason is there is edema and hemorrhage can be one cause which is restricting the motility. Second, it could be just entrapment of the muscle at the fracture site. So which muscles can be entrapped on the floor fracture? The inferior ones, inferior rectus, inferior oblique. So entrapment of muscle, which muscle? Common sense, it can be inferior rectus or inferior oblique. Or it could be actual injury, direct muscle injury. So any of these things will lead to diplopia. Any other feature we want to mention here? Which is the weakest wall of the orbit? It is the medial, so that can always be affected. If medial wall is affected, the sinuses will open. What are you going to get is subcutaneous emphysema. So what we are going to get is a subcutaneous emphysema. Okay, but only please note it down, if medial wall is affected, you are going to get this. And due to the pull of the muscle, very important point, it can actually incite a oculocardiac reflex. Now, when you say oculocardiac reflex, we will be discussing in squint chapter also how the pull on the muscle can lead to bradycardia and sometimes cardiac arrest through the vagus nerve. Right? So, the afferent is from the trigeminal and efferent from the vagus. This is your oculocardiac reflex. So, this can also happen in blowout fractures if there is a pull in the muscle. So, it can incite an oculocardiac reflex. So, that becomes very dangerous, of course. Right? So, these are the features. We come to investigation. Of course, we can go CT scan, or you can even do an X-ray PNS view can help us to see the fluid. So, whatever you do, either of this, what you get, let's understand that. We are getting, make this diagram. This is the floor fracture. Below this is what? Maxillary sinus. The sinus is filled with air, so it will be black. Right? So, against this black background, I am getting an opacity like this. This is what is called, repeated question of exam, teardrop sign. So, this is what is teardrop sign. So, what is teardrop sign? Which is an opacity against the black background of maxillary sinus. Here it is. So, this is the blowout fracture within ophthalmos. There is a chymosis, right? And this is what is teardrop sign we are talking about.
Question number 5. What is the term used to describe the refractive error seen in the ocular examination image of a 60-year-old patient who has complained of reduced distant vision, but no longer requires spectacles for near vision? Your options are. And the correct answer is index myopia. Here's the explanation.
First is myopia. Very simple, pay attention. M for M, myopia is that error in refractive error where the refractive power is more than required. So, we all know that if you look at the eye here, the light rays should be falling nicely on the retina, then we are all happy and we can see nicely. This is your emetropic stage. Now, if the power in this eye is more than what is required, then what will happen? The bending of light rays are going to be more and it is going to focus even before reaching the retina. This is myopia. And when your refractive power is less than what is required in an emetropic state, then now your bending is not sufficient. If your bending is not sufficient, it is finally going to focus behind the retina. This is hypermetropia. Okay? So, if we have understood, let's quickly write it. Myopia, M for M is more power. So, more power in eye than required. Number 1. Right? Number 1. Number 2, light rays. Let's quickly make the diagram. Light rays are focused in front of the retina. Now, we need the focusing. We need the focusing on the retina. So, you have to decrease the power. How do you decrease the power? Concave lens to get the focusing here. How much do I need to decrease the power to focus on the retina? This is the measure of my myopia, how much I have to decrease the power. Therefore, myopia is always indicated as minus. How much I am decreasing. Got it? Okay, so once we know this, then once we know what is myopia, how do you classify this? We can classify it as it can be axial myopia. When the axial length is more, we call it axial myopia. More axial length. It can be curvature myopia where more power is actually due to more curvature of the cornea. This is more corneal curvature is curvature myopia. Then index myopia means this time it is more refractive index, right, of the lens mainly we are talking about. Fourth one, positional, okay, positional myopia. Positional myopia means any dislocation of the lens, anterior dislocation can lead to more power. These are the classifications of myopia. Then we talk about is how will the patient present. Patient is going to present with, we all know this, half of us are more than that are myopic. So blurred vision, for far, mainly for the far. So this is the complaint of the patient, blurring of vision for far, or difficulty or diminution of vision for the far vision. And when you are examining this myopic patient, what are the other features we can see? Let's make a diagram and label it. So what do you see here? One by one, first is a long eye. Okay, so more axial length or long eye. Axial length is more, right? Secondly, what you will see, because there is a stretching of the eyeball, there is thin sclera. Thirdly, what you see is deep anterior chamber. And what about the ciliary muscles that help in accommodation? Accommodation purpose is to increase the power of your eye. But your power is already too much. I don't require that much. That means your ciliary muscles are not working, taking rest, and they become weak and sometimes even atrophic. Okay. So no stimulus for accommodation means ciliary muscle atrophy. Are weak or they become later atrophy. They atrophy. Okay. So anything else I want to comment? Yes, retinal changes, especially in pathological myopia. What are the retinal changes of pathological myopia? We are going to learn in retina chapter.
Question number 6. The person in the image is at risk of developing? Your options are, and the correct answer is exposure keratopathy. Here's the explanation.
Leg of ophthalmos. When the eye cannot close, we call it leg of ophthalmos. Inability to close the eye. Right? This will happen in facial palsy, that is 7th nerve palsy. It's a feature of 7th nerve palsy which supplies the orbicularis oculi. Now what is the main issue? If the eye is not closing, cornea is getting exposed and that is affecting the cornea, which is leading to exposure keratopathy. It can be cause of blindness if we don't take care of it. Right? So due to the facial nerve palsy, this problem that is happening, this whole condition is called neuroparalytic keratitis. We call it neuroparalytic keratitis. And do you all remember, we talked in cornea, what is your neurotrophic keratitis? That was due to 5th nerve, right? Where the health of the corneal epithelium is compromised due to no sensory supply.
Question number 7. What is the likely diagnosis from the image given below? Your options are, and the correct answer is pterygium. Here's the explanation.
Pterygium. Okay. Make the diagram. I know everybody knows what is pterygium. So, look at this. We all know this triangular fibrovascular subepithelial ingrowth, isn't it? So, this is the fibrovascular subepithelial ingrowth. It is a subepithelial ingrowth of bulbar conjunctiva over the limbus. Can we write it? What is pterygium? Write down here. I am writing for you. Please make the diagram also. Draw it on your copy like this. And now write the diagram and write the definition. Write down. It is a triangular fibrovascular subepithelial ingrowth of bulbar conjunctiva. Over the limbus. Okay? Over the limbus.
Question number 8. What will be observed in a patient diagnosed with sympathetic ophthalmitis and a history of penetrating eye injury? Your options are, and the correct answer is panuveitis. Here's the explanation.
This is injury in one eye is causing uveitis in the other eye. That is why it is called sympathetic. The other eye has not been injured, but still there is uveitis there. Okay, got it? So which injury? That is the first question. It is always a perforating injury, especially in which there is iris prolapse. Okay. This is going to lead to uveitis, of course, will happen in the eye which is injured, but this is causing uveitis of other eye as well, and this uveitis of the other eye is what is called sympathetic ophthalmitis. So this other eye is called what? It is called sympathizing eye. And the eye which is traumatized is what is called exciting eye. So common sense why it is happening. So this is due to autoimmune reaction towards uveal tissue. So there has to be some autoimmune reaction towards uveal tissue that affects even the other eye. So the antigen, particularly the antigen, these are all melanin containing tissues. The antigen that is responsible, if they ask you, they have never asked you this, but if they ask you, one name that we will say is retinal S antigen. So it is not only in retina though, so don't get confused. We'll just say retinal S antigen. Next they will ask you is, okay, today is the injury, when will we expect a sympathetic ophthalmitis in the other eye? So it has been seen how much time it takes for any autoimmunity to develop, at least 2 weeks. So it will never happen before 2 weeks. This is another exam question, see I have put a Q there. So never before 2 weeks, very important topic. Maximum chances are that it manifests after 2 weeks, from 2 weeks to 3 months time. Majority of the cases, the maximum chances in this duration. And sometimes it can be as long as after years. But yes, this is majority of the patients will manifest within this time period. What is causing? What type of uveitis? This is the next question in the box, all of you. It's a granulomatous panuveitis. So it's a granulomatous panuveitis.
Question number 9. A 5-year-old boy presents with a small nodule on the sclera as shown in the image below. What is the likely diagnosis? Your options are, and the correct answer is dermoid cyst. Here's the explanation.
A small child with, I see a bulge which is almost at the suture line. This is a case of dermoid cyst. We are talking about dermoid cyst. So what is a dermoid cyst? Dermoid cyst is a choristoma. We all know what is choristoma? Which means a normal tissue is at the abnormal place. So it is mainly, so normal tissue at abnormal place. So this is mainly along the embryonic fissures. Okay? This is due to sequestration of embryonic epithelial cells and it is along embryonic fissure. I think you all know it better than even me, all the details, right? Most commonly here you will see is superotemporally. Just learn these 1 or 2 more points. Most commonly superotemporally, that is a frontozygomatic suture. Right? So these are some points regarding. We won't go into too much detail, not needed. I told you if they ask you most common benign intraorbital in children, first is capillary hemangioma, second will be this one.
Question number 10. What is the most probable diagnosis for a 7-year-old patient who presented with a white pupillary reflex and underwent enucleation, with histopathological examination revealing the presence of flexner intestine rosettes? Your options are, and the correct answer is retinoblastoma. Here's the explanation.
So the most common age we will answer is 18 months. So it is common within 3 years, both are true, but commonest 18 months. So if 18 months are given in the option, we have to mark this. If 3 years is given and 18 months is not given, then we mark 3 years. Got it? So number 1. Number 2, they will ask you, this has also been a Q, most common mode of presentation. Most common mode of presentation we all know is the white eye reflex, which is called leukocoria. Leuco is white, coria is pupil. So have a look, this is what is white eye. Normally this should be the normal reflex in the right eye of this child, but this is what is white eye reflex or leukocoria. Coria is pupil. Okay. And this is the retinoblastoma, that is a tumor in the retina. This is your retinoblastoma. Flexner Winter-Steiner. So this is our pattern of differentiated cells. Flexner Winter-Steiner are cells with columnar cells with a central lumen. Let's have a look. If you see, these are columnar cells with central lumen. This is what is Flexner Winter-Steiner. Right? We also call it rosettes. These are rosettes.
Question number 11. What is the diagnosis? Your options are, And the correct answer is pseudoexfoliation syndrome. Here's the explanation.
So we are talking about pseudoexfoliation syndrome. It is the most common secondary glaucoma, right? What story is almost similar to that we have learnt in pigmentary glaucoma. So what is happening here? Let's understand. Make the diagram, please. So this time what is happening is, it is the dandruff-like material which is getting deposited. This is a dandruff-like grey-white fibrily material. This is deposited on the lens capsule, in the suspensory ligaments, at the back of the cornea, and the same dandruff-like deposits are going to block the trabecular meshwork. So story is same in pigmentary glaucoma, it was the pigments, whereas in pseudoexfoliation syndrome, it is mainly the dandruff-like material which is blocking the trabecular meshwork. Leading to which type of glaucoma if there is a block in trabecular meshwork, all of you? It is secondary open angle glaucoma. Once you know this, that this time it is, let's write it. It is grey-white fibrily, grey-white okay, dandruff-like material. Okay, this is how you will describe dandruff-like material. Why this is, from where it is coming? It is mainly some abnormal extracellular matrix metabolism. So it is an abnormal extracellular matrix metabolism in the ocular tissues which is actually causing the release of these. So it's not a true exfoliation. That is why if you see we are calling it pseudo exfoliation. It's not a true exfoliation, it's a pseudo exfoliation, right? So these dandruff-like material, what are the features, what do we see in the eye and how it is causing a problem, right? So first of all, why it is happening? We'll first talk about it. So it is generally associated with, point number 1, with the, it is considered to be genetic. The gene associated is LOXL1. This is in chromosome number 15. So mainly the etiology, it is genetic in origin. The name of the gene LOXL1, okay, yeah, in chromosome 15. It is mainly seen in age group of more than 50 years. The biggest risk is it is causing open angle glaucoma, and because it is weakening the suspensory ligaments, it is one of the reasons of subluxation of lens. Then it can be a very big challenge during cataract surgery. Okay, so during cataract surgery, the lens suspensory ligament is so weak, the capsular bag itself is so weak that it's very difficult to retain the bag. When you are doing the cataract, the whole bag comes out. So it's very difficult to retain it, right? So we have to keep that in mind, and before operating any patient of the cataract, I should know whether he is a case of pseudoexfoliation syndrome or not. And as I told you, because it is one of the most common secondary glaucomas, correct? So you will see it very commonly. So you should always look for pseudoexfoliation syndrome in the pre-op patients, right? Especially for cataract. Okay, so once we know why it happens, and it is mainly of the gene, which gene is responsible. Also remember, it may be associated with some systemic diseases. So it can be associated with hearing loss, okay, and it can be associated with some heart problems, right? So with some serious disorders. Okay, now what are the findings? Very, very important. What are we saying? Let us draw another diagram to learn all the findings. So this dandruff, I'll show you the slides also. First, let us draw in for ourselves. So the dandruff-like material, where are we going to find? First of all, we said at the back of the cornea, right? SKPs, right? So these can be deposited at the back of the cornea. And sometimes it can be Krukenberg spindles, though it is less common than pigmentary, but yes, it may be spindle shape. Then we call it Krukenberg spindles. When you look at the pupillary border, I am making a small diagram here to make you understand. So in the pupillary border, I can see the depositions like this, right? So here I will make the depositions on the pupillary border, right? So there is loss of pupillary ruff. At the margin there is a deposition of the dye. Then on the lens, okay, so it is deposited in such a way that there is between a clear area which is called hoarfrost sign. Let us note down hoarfrost sign. Hoarfrost sign. Of course, in the TM, it is deposited in the trabecular meshwork and causing secondary open angle glaucoma. Right, all of you? And cataracts will be more common. Another important thing we have to know, when I am talking about systemic, you can write along with that only. Associated with hearing loss, with serious disorders. One more point please add here. It is seen, now this is little above your level, you may learn it, you may not learn it, but I am just giving some additional point here, that there is more homocysteine level in the plasma and aqueous humor. Okay, in these patients more homocysteine levels in plasma and aqueous humor. And there is a folate deficiency, it precipitates faster. Okay, precipitates more in folate deficiency. Even if you don't learn it, I don't mind. This was a little extra point I just gave. Okay. Then once you know what are the findings and what the problem it can cause, why it happens, now how will we manage? It is almost the same way as pigmentary glaucoma. That is, I will give the treatment as medical, anti-glaucoma drugs can be given, or it could be very effective is argon laser trabeculoplasty. The main problem is in the trabecular meshwork. ALT is very effective. I'll talk about ALT shortly. Let's see the signs. So this is your dandruff-like material. Can you see them? All deposited like this, here and here, right? So the dandruff-like deposits here. Loss of it, the pupillary rough has all been lost. It becomes more smoother. Again, this dandruff-like material we can see here. I think it's absolutely clear.
Don't forget to like and subscribe if you found the video interesting. See you in the next one.